Let's start by examining the radiographs first. The AP and lateral views of the knee show distinct periosteal thickening involving the diametaphyseal regions of the tibia, fibula, and femur. The thickening appears lamellated, suggesting a periosteal reaction, but what's crucial here is the sparing of the epiphyses. This immediately helps narrow down the differential diagnosis. The absence of any significant bony destruction or fractures is another important finding to note. Additionally, there is a small joint effusion, but nothing overly concerning in that regard. Now let's move on to consider the possible causes of this periosteal reaction. If this finding were unilateral, I would be considering a vascular cause, or perhaps even a local trauma or infection. However, with bilateral involvement, my thoughts are more aligned with systemic causes. Given that the periosteal reaction is isolated to the diametaphyseal regions and spares the epiphyses, the differential diagnosis is further narrowed down. The possibility of hypertrophic osteoarthropathy, HOA, comes to mind, particularly secondary HOA, which is frequently associated with chronic pulmonary diseases, especially bronchogenic carcinoma. At this stage, I would typically suggest correlating these radiographic findings with clinical history. Does the patient have a history of chronic cough, smoking, or other pulmonary symptoms? If so, this strengthens the suspicion of HOA secondary to an underlying lung pathology. The next logical step would be a chest radiograph to check for pulmonary disease or mass. Next, the bone scintigraphy adds an additional layer to our analysis. The scan reveals increased tracer uptake along the diametaphyseal cortical margins, especially in the lower limbs. This supports the diagnosis of hypertrophic pulmonary osteoarthropathy, HPOA, given the systemic nature of the uptake, further ruling out more localized causes of periosteal reaction. Differential diagnoses to consider here would include hypervitaminosis A, which can cause a similar appearance, and pachydermoperiostosis, although the latter typically involves the epiphyses. Given the sparing of the epiphyses, these differentials seem less likely in this case. In conclusion, based on the bilateral nature of the periosteal reaction, its distribution, and the findings on bone scintigraphy, hypertrophic pulmonary osteoarthropathy, HPOA, is the leading diagnosis. Further imaging, particularly of the chest, would be critical in confirming any underlying pulmonary pathology, most commonly bronchogenic carcinoma. If you found this analysis helpful, please subscribe to Radiology Made Easy, and feel free to drop any questions or cases in the comments. Let's keep growing and learning together.